speaker is Dr. Nitish Prabhar. Now I'd like to invite Dr. Dev to come to the dais.
At the outset, I should thank Dr. Karthik for giving me an opportunity. I have to give a small apology that this is a very simple case. I know how difficult that topic is because presently my three postgraduates are doing PG thesis presentation in osteoporosis. So she made it actually look very simple, but it's a very, very difficult topic. And Karthik, I think, has covered it extensively with his doubts. Ours is a very simple case, and there are more practical aspects to manage simple day-to-day diabetes and hypoglycemia than what meets the eye. So I'll start off as a Lalit and Mohanlal fan with the last flop that he gave us, and social media was abuzz with this കണ്ടത് നിജം കാണാത്തത് പോയി നീ കണ്ടതെല്ലാം പോയി ഇനി കാണാൻ പോകുന്ന നിജം. I remember when I went last February for a meeting in Toronto on a literary meet, there was actually a debate about who liked Malaiko to Valiban and who was against Malaiko to Valiban. So we're not going to divide the group. As we are running late, I think I'll ask Nitish to present it, and then as time permits, we'll take questions on how this was solved. Thank you.
12th of June 2024, a 58-year-old gentleman was brought to our emergency department at around 10:30 a.m. in the morning, being found unconscious. He was last seen conscious at around 8:30 a.m. by his younger son. In the ED, he was hypotensive, his BP was around 60/40 millimeter of mercury, and he was hypoglycemic with the glucometer RBS reading low. He is a person with diabetes for about 25 plus years. He is on insulin, a long-acting insulin of glargine and rapid-acting insulin of aspart, along with steroids. He was given stress dose of hydrocortisone considering he was on steroids, and he was started on 25% dextrose, normal saline, and iotrust from emergency department. A CT brain was done to roll out any ICH, is turned normal. An ECG was done, it showed no acute STT changes. He was shifted to MICU for further care. At the time of our arrival in MICU, he was comatose, his GCS was E1, V1, M1, and his pulse rate was 89 per minute, and his BP was 120/90 millimeter of mercury on average 103 ml per hour. His respiratory rate was 12 per minute, and his GRBS was 35 milligram per deciliter. He was given a bolus of 25% dextrose. Being comatose, he was intubated and mechanically ventilated. He was persistently hypoglycemic, and he was started on 25% dextrose infusion along with IV hydrocortisone 100 milligram TID. His history was reviewed, and for the past 2 months, he has had recurrent episodes of hypoglycemia, and he is evaluated 2 tertiary hospitals of Kochi. He was labeled as autoimmune antibody-mediated hypoglycemia, for which he was on steroids. He was initially on steroids at a dose of 80 milligram per day. When he presented to us, he was on prednisone 30 milligram per day. At this point of time, our provisional diagnosis was severe hypoglycemia, shock, hypoglycemic encephalopathy, autoimmune antibody-mediated hypoglycemia, and type 2 diabetes mellitus. The possibilities which we considered were Addison's crisis and sepsis, considering he was on steroids. So we continued with our initial investigations, which showed a total count of 8,300 cells, and renal and liver parameters were within normal limits. A C-reactive protein and procalcitonin were negative. A random cortisol was 4.95, which was albeit on a lower borderline level. Considering steroids, it was acceptable, and his HbA1c was elevated at 9.2%. So we were able to get his previous documents, and his case history was again reviewed. For the past 2 months, he had multiple random blood sugars reading less than 70 milligram per deciliter. His anti-insulin antibodies was around 34.1, with a positive reference of more than 18, and his insulin was slightly elevated at 38.8 intraunits per ml. In view of refractory and severe hypoglycemia of deep coma, an emergency endocrine opinion was obtained. A decision to reconsider his previous diagnosis was made, considering the low antibody titer and him being persistently hypoglycemic. An anti-insulin antibody level was repeated, and urine screening for toxins, including sulfonylureas, was also sent to Amrita. In the meantime, he was continued on IV 25% dextrose, and octreotide was also started, considering persisting hypoglycemia, and he remained comatose the entire night. At this juncture, we were actually thinking of doing an EEG to consider his brain activity, considering he was persistently hypoglycemic. Fortunately, the next day he regained consciousness, and he was extubated, and he was started on high caloric diet. We got a history from the patient himself, but he didn't have any history of injecting excess insulin, injection of sulfonylureas, or skipping steroids. So a critical sample blood glucose, insulin levels, and C-peptide levels and cortisol levels were done. He remained on 25% dextrose IV infusion for about 43 hours and was continued on high-dose steroids, considering steroid dependence for 2 months. While awaiting hypoglycemia evaluation reports, we got a key history from his son that he had found around 8 vials of used insulin at his home. Now we are able to get the hypoglycemia evaluation reports. His insulin levels were sky high with a range of more than 1000 units per ml. His C-peptide level was markedly low at 15 picomoles per liter. Only one diagnosis could possibly explain this both values, which could be exogenous insulin. His anti-insulin antibody was negative. His urine sulfonyl screen was negative, and his cortisol was 51.9 microgram per deciliter, which is high considering the stress he was on. To substantiate our diagnosis, we were able to get his e-bill from pharmacy, which he just procured 2 days prior to the incident. He was able to procure 3 cartridges of Glargine, 3 cartridges of Rhizodeb, 3 cartridges of Aspart, and 2 vials of Mixtard just 2 days prior to the incident. In all probability, he would have injected himself with around 3,750 units of insulin on the day of his hypoglycemic episode. So our diagnosis is crystal clear, which is severe hypoglycemia, self-induced, hypoglycemic encephalopathy with coma, type 2 diabetes mellitus, and probably steroid dependence. When we got to find out the reason why he did go to such extreme, and he was a claim patient on insurance, we couldn't let him go with a diagnosis like this. So we go to a further extreme, and we did a Doppler PET scan to see there is any finding which we could write on his diagnosis. Doppler PET scan came to be normally appearing pancreases with no evidence of insulinoma, no evidence of extrapancreatic insulin secreting lesions, but beta cell hyperplasia in the head of pancreas was seen. During the rest of his course, he had intermittent hypoglycemia episodes in the ward. He required 10% dextrose IV for about 76 hours to maintain sugars between 100 to 200 milligram per deciliter. His steroids was being tapered slowly. A psychiatric counseling was given considering his deliberate self-harm. He was discharged on probably the most safest OHS we could give to him. Metformin of 500 milligram TID, a vildagliptin of 15 milligram BD, along with Hyzone of 10 milligram and 5 milligram. He is on regular follow-up in our OPD at endocrinology, general medicine, and psychiatry departments. He was last seen 2 weeks ago. Now his steroids have completely been tapered off. Despite no steroids, he has no episodes of hypoglycemia. Currently, he is on a combination of repaglinide and vaglibus along with vildagliptin and metformin. Discussion. Insulin autoimmune syndrome. It was described by Dr. Hirata in the year 1970, also known as Hirata's disease. It is the third leading cause of autoimmune hypoglycemia in Japan and rare in the rest of the globe. It has no gender predilection, usually seen after 40 years of age. It usually presents as postpartum hypoglycemia with Whipple's triad. Classification. There are 2 modes of classification. One is classical and non-classical. In classical, it has been described in a person who hasn't taken any insulin in any point of his life. In non-classical, there is a history of exogenous insulin injection, mainly Glargine. In our patient, when his previous report showed an anti-insulin antibody level of positive, his Glargine intake could probably explain the positivity. The other classification can be primary, which is idiopathic, and drug-induced. The commonly implicated drugs are methimazole, lipoic acid, clopidogrel, captopril, omeprazole, and esomeprazole. And autoimmune disorders such as Graves' disease, Hashimoto's thyroiditis, SLE, rheumatoid arthritis, ANCA-associated vasculitis, Sjogren syndrome, and multiple myeloma. Regarding the pathophysiology, the culprit antibody is anti-insulin antibody. When you look at the glossary, it's like antibodies against the insulin. So ideally, the patient should have hyperglycemia. But the answer lies in the pathophysiology. What happens is, the insulin has an A chain and B chain connected by a disulfide bond. When there is a trigger, the disulfide bond gets broken and the patient will be exposed to the A chain and B chain, which cause the T cell and B cells to become active. When a patient with insulin autoimmune syndrome has a meal, there is a postpartum hyperglycemia. In response to it, the pancreas secretes more insulin. At this point, there will be further production of antibodies. The antibodies and the insulin form an immune complex, which prevents the antibody from acting on peripheral receptors. So, pancreas will sense there is further glycemia and it produces further insulin, leading to production of further antibodies and antibody immune complexes which prevent insulin from acting on its peripheral receptors. At one point of time, the immune complex gets dissociated. At this point, the insulin is completely free to act on its peripheral receptors, leading to profound hypoglycemia. The diagnosis includes a high insulin level of more than 1000, with the insulin C15 molar ratio of more than 1, and an autoimmune antibody present. Regarding the treatment, it usually is self-limiting disease. The triggers should be avoided. Usually, if the triggers are avoided, the symptoms will resolve by 6 months. The diet includes small meals, and avoid monosaccharides to prevent postprandial excursions. Acarbose and vocalibose to delay the postprandial hyperglycemia. Glucocorticoids, mainly methylprednisolone for immunosuppression. Other immunosuppressants like azathioprine or rituximab, and plasma exchange to remove the circulating antibodies, and diazoxide to inhibit the insulin secretion. Approach to hypoglycemia. Hypoglycemia is a commonly encountered medical emergency. It is seen in both patients with diabetes and patients who are not diabetics. The insulin is much more common in a patient with diabetes. The factors which could predispose hypoglycemia in a patient with diabetes includes drugs, mainly insulin, sulfonylureas, meglitides, and quinolones, and reduced food intake. In conditions as patient takes the adequate amount of insulin but fails to have food. Excess physical exertion, commonly seen in type 1 diabetics. Improved glycemic control can also present as hypoglycemia. Alcohol. What happens with alcohol is when you have a binge drink of alcohol, it increases the NAD ratio, which inhibits the TCA cycle, and excess intake of alcohol also decreases substrate for glycogenolysis and gluconeogenesis in the liver. And critical illness such as CKD, acute liver failure, congestive cardiac failure, and sepsis. The causes of hypoglycemia can be seen in a patient with ill or a medical individual or a person who is seemingly normal. The causes of include drugs, which I mentioned earlier, and critical illness like sepsis. In sepsis, increased inflammatory markers causes the macrophage to be activated, which increases the macrophage uptake of glucose. An acute liver failure, there is the decreased substrate leading for hepatic glycogenolysis and gluconeogenesis. In CKD, there is a gluconeogenesis impact. In congestive cardiac failure, the congestive hepatitis and ischemic hepatitis leading to liver dysfunction. And hormone deficiencies such as cortisol, growth hormone, thyroid, or epinephrine. And non-islet tumors such as mesenchymal tumors, ACC, which is adenocorticocarcinoma, hepatoma, and carcinoids, in which there is an increased production of insulin growth factor. And a patient who is seemingly normal, the differential diagnosis is endogenous hyperinsulinism. The causes include insulinomas, functional beta cell disorders like beta cell hyperplasia, and non-insulinoma pancreatogenous hyperinsulinism, and insulin autoimmune syndrome. The two antibodies which include, one is anti-insulin antibody and the second is anti-insulin receptor antibody, which acts as an agonist on the insulin receptor. And insulin secretagogues such as meglitinides and sulfonylureas, and disorders of gluconeogenesis and fatty oxide oxidation, commonly seen in children, and accidental or malicious hypoglycemia. Evaluation of hypoglycemia. Any patient who presents with the confusion, seizures, altered consciousness, profuse sweating, and palpitations should have their blood glucose measured. The evaluation goes like the first step is always take a detailed history of the drugs he is on, whether he has a recent alcohol history, and whether there is a possibility of a malicious hypoglycemia. If this is negative, go for the second step, which is to assess for the critical illness, which is sepsis, acute liver failure, congestive cardiac failure, and CKD. If this is negative, go for the hormone workup, which is cortisol, growth hormone, epinephrine. If all these turn negative, the next step is to evaluate for endogenous hyperinsulinism. When the patient is having hypoglycemic episode, send for plasma glucose, plasma insulin, plasma C-peptide, plasma proinsulin, and beta hydroxybutyrate. Depending upon the above investigation, the further evaluation will go into imaging or antibody workup. For insulinomas, the probable imaging could be endoscopic ultrasound, somatostatin receptor scintigraphy, or a data PET scan. The treatment of hypoglycemia. The patient is able to take orally and is willing the initial dose of 15 to 20 grams of glucose to be given. If he is unable to take orally, preferably a parenteral therapy to be given with a 25% dextrose followed by serial monitoring. If IV therapy is not practical, 1 milligram of glucagon could be given subcutaneously or intramuscularly. In case of insulinoma, if these measures fail, diazoxide alkaloate can be given, which inhibit the insulin secretion. In case of deficiency of hormones, the deficient hormone has to be supplemented. Conclusion: it is pragmatic to reconsider the diagnosis if the clinical presentation doesn't fit the disease. A high emphasis should be given to a detailed history. Plausibility of a rare diagnosis in a clinical setting should always be reviewed. And before starting a steroids in a patient diabetic, it has to be thought twice before initiation. Insurance claim assets for the family has to be appreciated like our patient. Some difficulties in documenting self-harm and psychiatric illness and medications have to be brought forward in clinical practice, and potential of self-harm involved has to be explored. Our patient had all probabilities of injecting himself again with insulin in the ward. He had to be overseen, and his risk has to be mitigated. I'd like to finish my presentation with a few words. There's a famous saying in Tamil which goes by Kannal Kanpadumpai, Kadal Ketpadumpai, Tira Visaripudumai, which roughly translates to whatever seen with eyes isn't true. Whatever is heard with ears isn't true. Whatever is found through elaborate inquiry is the truth. The below picture is probably the most famous fictional medical character, Dr. Housandi. In this picture, he says everybody lies. We got history from the patient multiple times, but he lied. And in all the episodes, he used to get the diagnosis going through a back door through some directory works. We got the diagnosis through the back door through e-bill pharmacy, from pharmacy. Thank you.
Has simplified how tough this was, because this patient, to be very honest, was in my 20 years of practice the only patient I actually seriously thought of asking the neurologist for a repeat EEG in the morning, because the family was desperately poor. They were giving me the clue from the way they were telling, please don't push ventilation any further if Achan doesn't survive or any chance to survive. And the son told me he's in a debt of 1.5 crores. He was involved in some financial issues and all. So we asked the neurologist to come. I was very clearly remembering neurologist coming in. We did an EEG late night, and sir said, okay, we'll have to give them a repeat EEG by 12 hours if we have to declare a brain death. By early morning, I have rattled all my brains trying to see what is happening, because he's on 25% continuous infusion and he's still having hypos. So we checked multiple glucometers, we sent to the lab, they're all coming as 30, 32, 35. And it's scary. Then critical care suggested Dr. tried thinking of insulinomas, things like that. And they were getting the reports from outside also in between. I think I lost more sleep. By the time I came early morning, neurologist is coming ready to see the EEG, and this fellow is sitting up and eating idlis. So that was, a pleasant surprise, but shocking. So when Dr. Avashan Nair, he comes from Angamali. So sir came early morning. First thing he comes to ICU and he asked me, Arkado EEG, Tanikano, Yagano. That was a real joke that he told. But the fact remains, the first take-home point that I think we should all learn is, in all difficult diagnosis, there is still a simple diagnosis hiding somewhere. So hypoglycemia was something which was explaining everything. Second issue was, now how do you document something like this? So we went through his history, the antibody positivity, autoantibody syndrome, 2 endocrine diagnosis from 2 eminent hospitals of Kochi. You have to be digging deeper and deeper. Finally, we said, okay, get the antibody levels now. That is when you saw the levels which are slightly high. Now, when you look at the literature regarding autoantibody syndromes, they will never cause such profound, long-lasting hypoglycemias. That was actually the big clue. And those levels are not big enough. So that is why when somebody tells you that he's positive, please look at the reports also. And when I asked him to show me the report, was a time when I actually digged up my doubts, because he told me, sir, I'll have to get it from home. I said, then how did these 2 hospitals give you the diagnosis? And he said it was all sent out, and patient was discharged for a PET scan to another center, because the first hospital didn't have a PET center, and they have collected this on their own. So nobody has actually seen this physical report other than the fact that it is literally positive. But the titer was what sent us doubtful. Now, look at the serendipity, or what you call as Devanagram of this man. The moment I asked him, is there anything that you are suspecting as a foul play? Because he maintains that he's never taken it. His son said, അമ്മ ഭയങ്കര വൃത്തിപ്രാന്തിയാണ്, വീട് എപ്പോഴും വൃത്തിയാക്കി ഇടും, പക്ഷെ ഇന്ന് അച്ഛന്റെ മുറിയിൽ 8 വയലുണ്ട്. So for somebody who's on basal bolus, 8 vials, as senior practitioners, in 1 week he will have 8 vials sitting there. You saw the doses that he was being prescribed. So 8 vials is not suspicious. But something in us kept digging further. So he asked, where do you get the vials? So he told the name of a medical shop, which most senior practitioners will know, was a shop owned by our ex-Lilly Sharath. Okay, so JP came and said, why don't we just ask Sharath to give us the EB? Now, this is the biggest tragedy that we all should be worried about. How did a man who has no prescription is going to be written like that? Because these are drugs which we are not going to combine at any cost. So we actually asked Sharath to get us the bill. Once he sent the bill, he himself smelt a problem. So he said, sir, am I going to be penalized? Because this is suicide. Why did he issue so many drugs? So this man is hyper smart. He's told, this is for me, my mother, my brother, and my father. But still, look at the dangers. So he's got this, and if you see that list of insulins, they are all hyper long acting, ultra long acting, and the unit says 3,750 units. Now that brought us to the question. So that e-bill was basically clinching the diagnosis. Now the problem is, how do you shift this guy out into the ward? And all our pens, if you don't notice, most of the times it's at the bedside. So he's been in 2 hospitals. Most of the times he must have been injecting it even inside the hospital bedside. Who's going to suspect? Especially in these busy times, I'm sure none of our hospitals have enough staff to go and take it by himself, and they are going. So he's probably self-injected even inside 2 tertiary care hospitals before coming here. So my job was more like a detective. In fact, in one of our in-house presentations, we had myself as Seduramayar, another fellow acting as one police in the comic that we put up for that. We had to literally go and pull out the drawers and make sure that he was not taking. On the 5th day, the patient finally accepted. He cried and he said that he's done self-harm. By that time, we got the psychiatrist to come in. Dr. John helped us. Now, imagine our plate. See, how do you put all this into the final bill? So we had 2 charts. We had one chart which was officially documented for the insurance purpose. We had an unofficial chart which is kept ready. I told both the sons, anything happens, I'm going to put all this together and back into the chart. Well, otherwise, we are liable to be sued. And Dr. John also gave us a psychiatric consultation in a separate chart. Now, if you saw, I'm sure all of you would have seen, there is a beta cell hyperplasia in that PET scan. So what I usually do is give the most confusing diagnosis on the final diagnosis for the insurance fellows. Anyway, they can't make head and tail of what has happened. So Exentin scan, DOTA scan, all that. So I went through with the endocrinologist. Just today also I was asking my nuclear medicine PET scan person, Ranjit, can you give me one of these images? He said, sir, don't show to an august audience of physicians because it's the most fallacy-prone investigation that anybody can send. So if you are ever sending an insulinoma workup, this is not the scan that they should be doing. I'm not naming who did it, but the problem is they are also forced to write something there. So the safest way to write a possible thing is a beta cell hyperplasia. Ranjit reviewed his scans and he said, sir, nothing is there. You give him the diagnosis, let him go, but tell the son that this is the probable thing. So what I'm doing now is, in the OPD prescriptions, I'm writing down fictitious self-induced harm, hypoglycemia. Now the other challenge was, what do you give him? What do you give him? Because you definitely can't send him home again with insulins now. So we had to choose metformin.
അതായത് അന്നൊക്കെ ഈ ഗൾഫിൽ നിന്ന് ഈ നേഴ്സുമാര് മക്കളുണ്ടെങ്കിൽ ഇൻസുലിൻ കൊണ്ടുവരും. അത് 100 IU ഇൻസുലിനാണ്. ഇവിടെ ഉള്ളത് 40 IU സിറിഞ്ചാണുള്ളത്. ഇവര് പലപ്പോഴും ഇത് ഈ വരുന്ന 30 യൂണിറ്റ് എടുത്തേക്കുന്ന ആളെ ഈ 100 IU ഇൻസുലിൻ 40 IU സിറിഞ്ച് എടുക്കും. ഒരുപാട് പ്രാവശ്യങ്ങളുണ്ട്. ഞാൻ അവസാനം സംശയം വരുമ്പോഴൊക്കെ നിങ്ങൾ ഇൻസുലിനും സിറിഞ്ചും കൊണ്ടുവന്ന് കാണിക്കാൻ പറയും. അങ്ങനെ നോക്കുമ്പോൾ ഇതൊരു 10-12 കേസെങ്കിലും ഇതേപോലെ ഹൈപ്പോഗ്ലൈസീമിയ ആയി പോയിട്ടുണ്ട്.
പറഞ്ഞു വളരെ കറക്റ്റാ. റൈറ്റ് നൗ ഐ ഹാവ് എ പേഷ്യന്റ് ഹു ഈസ് ഓൺ ബേസൽ ബോളസ് 5 doses of insulin. HbA1c is 40. And today when I asked them to bring everything, she was taking 40 IU and taking out from the insulin pen fills.
ഇനി വളരെ
അതെല്ലാം 100 IU ആണ്, പേഷ്യന്റ് 40 IU എടുത്ത് കീറുന്നു.
ഇനി വളരെ ട്രാജിക് ആയിട്ടുള്ള ഒരു ചരിത്രമുണ്ട്. കുറെ പേർക്ക് അറിയാമായിരിക്കും. ഒരു 35 കൊല്ലം മുമ്പ് ഈ കണ്ണോപ്പറേഷൻ കഴിഞ്ഞിട്ട് ഒരു നമ്മുടെ ഇതുണ്ടല്ലോ, ട്രൈമത്തോപ്പറും സൾഫാമിത്തോസും കോംസാറ്റ് ഫോട്ടോ എന്നൊരു ഗുളിക ഉണ്ടായിരുന്നു, ഈ ബോറിംഗറിനോളിന്റെ. അത് കൊടുത്ത ഒരു 10-15 പേര് മരിച്ചു കഴിഞ്ഞാൽ ആദ്യമൊന്നും കാരണം കണ്ടുപിടിക്കില്ല. എല്ലാവർക്കും ഷുഗർ കുറവാണ്, ഹൈപ്പോഗ്ലൈസീമിയ. ഇവര് പറഞ്ഞു ഞങ്ങൾ കൊടുത്തേക്കുന്ന കോംസാറ്റ് ഫോർട്ടാണ്, വേറെ ഒരു മരുന്ന് കൊടുത്തില്ല. കണ്ണോപ്പറേഷൻ കഴിഞ്ഞ് കണ്ണിന് കുഴപ്പമില്ല. 10-15 പേര് മരിച്ചു. അത് പിന്നെ അവസാനം അത് വലിയൊരു ഇത് പറഞ്ഞ പോലെ ഒരുപാട് ഫോളോ അപ്പ് കഴിഞ്ഞപ്പോൾ അവസാനം കണ്ടുപിടിക്കുന്നത് ഈ ബോറിംഗറിനോളിന്റെ തന്നെ ഒരു ആന്റി ഡയബറ്റിക് സൾഫണേറിയൂറിയ ഉണ്ടായിരുന്നു അന്ന്, ഈ ഗ്ലൂക്കോൺ അന്തർവില. ഇത് ഈ കോംസാറ്റ് ഫോർട്ടിന്റെ വരെ എങ്ങനെയും മിക്സ് ചെയ്തു പോയി. ചുരുക്കി പറഞ്ഞാൽ ആ ഡോസിൽ അങ്ങനെ വന്ന അത് ഇതുപോലെ കണ്ടുപിടിക്കാൻ പറ്റാത്ത ഒരു ഹൈപ്പോഗ്ലൈസീമിയ, 10-15 പേര് മരിക്കുകയും ഇടയായി. ഇതിപ്പം ഈ പേഷ്യന്റ് 100% രക്ഷപ്പെട്ടു. ദീപു ജോർജിനെ അഭിനന്ദിക്കുന്നു. പക്ഷെ ഇങ്ങനെ ഒരു സംഭവം ഉണ്ടായിട്ടുണ്ട്.
It was a teamwork. In fact, for the sake of the August audience, I'll tell you, even I didn't know that Amrita was actually doing toxicology profiling for sulfonylureas also. അത് ഭയങ്കര യൂസ്ഫുൾ ഒരു ടെസ്റ്റാണ്, വലിയ വിലയില്ല. ഉള്ളി തിങ്സ് നമ്മളത് ചോദിച്ചു വിടണം. സൾഫോൺലൂറിയ ലെവൽ ഇൻ യൂറിൻ നമ്മൾ ചിന്തിക്കുക പോലുമില്ല. പക്ഷെ ജയപ്രകാശ് ആലോചിച്ചാണ് അത് പറഞ്ഞത്. ബിക്കോസ് സൾഫോൺലൂറിയ അഗെയിൻ ഇപ്പൊ നമ്മൾ ഡയോണിൽ എടുത്ത് കഴിച്ചാൽ ഈ 72 hours എക്സ്പ്ലെയിൻ ചെയ്യാം.
ഞാനീ പറഞ്ഞ കേസ് ഇതുപോലാണ് സംഭവിച്ചത്. തെറ്റായിട്ട് മെഡിസിൻ വന്നു, അത് ആരും കണ്ടുപിടിച്ചില്ല. ആണ് എങ്ങനെ അറിയുന്നത്? കോംസാറ്റ് ഫോർട്ട് എന്ന് പറഞ്ഞൊരു ഗുളിക അത് കൊടുക്കുകയാണ്. അതിനകത്ത് പക്ഷെ ഉണ്ടായിരുന്ന കണ്ടന്റ് സൾഫണേറിയൂറിയ.
ഈ നമ്മൾ ഈ ഡ്രഗ് ഇൻഡ്യൂസ്ഡ് ഓട്ടോ ആന്റിബോഡീസിൽ ഐ തിങ്ക് ദ കോമണസ്റ്റ് കൾപ്രിറ്റ്സ് ആർ അവർ ഹെവി ഡോസ് ഓഫ് മൾട്ടിവൈറ്റമിൻസ്. Most of our patients on very high dose of methylcobalamin, അത് ഇത് ചപ്പയോറെല്ലാം, one of them can cause unexpected hypoglycemias when we checked up literature. പക്ഷെ അതൊരിക്കലും ഇത്രയും ടൈം പോവില്ല. You know, this guy almost died. If you saw his BP and all, he was unrecordably low. അപ്പം most of the times we see patients who come with hypoglycemia, late night, sudden sweating. നമ്മളപ്പം brittle diabetes അല്ലെങ്കിൽ hypoglycemia അൺഅവയർനെസ് അല്ലെന്നുണ്ടെങ്കിൽ ഒരു സോമോഗി ഡോൺ ഫിനോമിനൻ നമ്മളതൊക്കെ വിളിച്ചിട്ടുണ്ട്. പക്ഷെ ഈ ഓട്ടോ ആന്റിബോഡി സാധനങ്ങൾ വരും. The other thing that we thought was, can somebody be just having these antibodies because he's been taking insulin for such a long time? Those values are not high enough to even explain that. So for all you know, ഇയാളുടെ പ്രായം വെച്ചിട്ട് he might have been taking an earlier generation insulin also before this. So I think the take home message is, before we accept a diagnosis even from a well-known institution, be very, very guarded if that doesn't fit into what you're seeing.